atrial flutter was very nicely explained in the year 1927 by Dr. Thomas Lewis. And when somebody asked him what is happening in the heart of a patient with atrial flutter, he replied, it's due to a re-entry within the right atrium. So he said in the year 1927. So when the terminal portion of the flutter wave coincides with the positive deflection in lead V1, we can close our eyes and say blindly that the origin of the arrhythmogenic substrate is located in the area of the heart called cavo-tricuspid isthmus. So this is a very rare in electrophysiology where a particular ECG pattern correlates with the cardiac anatomy. So this is a ECG I was talking to you about. When you see the terminal portion, you can see the typical sawtooth appearance of the flutter waves in the inferior leads. So this is a typical atrial flutter, and here the terminal portion of the flutter wave coincides with the positive deflection of the P wave in lead V1. So the arrhythmogenic substrate is located in the cavo-tricuspid isthmus. So before going into the anatomy of the right atrium proper, I will say few points about the development of right atrium. The anatomical right atrium develops from the primitive right atrium and the sinus venosus. There are two valves guarding the sinus venosus, and the right valve regresses between the 9th and the 15th week of gestation. Its superior portion forming the crista terminalis, and the inferior portion forming the eustachian valve, which guards the orifice of the inferior vena cava, and the Thebetian valve, which guards the orifice of the CS. So now coming to the right atrial anatomy, the normal right atrium has an ellipsoidal shape, and it has got a venous component, it has got an appendage and a vestibule, and it has got 6 important structures, namely crista terminalis, cavo-tricuspid isthmus, then eustachian valve, eustachian ridge, arch of the coronary sinus, and its valve, that is the Thebetian valve, tricuspid valve, and the right atrial appendage. So the crista terminalis is a muscular band which arises from the right atrial anteromedial border extending vertically along the SVC and IVC. Due to the non-uniformity of the myocardial structure arrangement both within and outside the crista terminalis, it acts as an anatomical conduction barrier. So this is a picture showing the anterior wall of the right atrium being opened up, and it is deflected from lateral to medial, and this ridge is a crista terminalis. This is on the endocardial aspect, whereas if you see on the epicardial aspect, there is a sulcus called sulcus terminalis, and this is the pectinate muscle, and this is the superior vena cava and the inferior vena cava, and you can see the fossa ovalis here, and the coronary sinus arch, and the tricuspid valve, and this is the most important structure, that is called the cavo-tricuspid isthmus, extending from the IVC to the tricuspid valve. And this is very important in the cavo-tricuspid isthmus dependent flutter. So the cavo-tricuspid isthmus is a well-established location of atrial tissue. It has got a quadrilateral shape. It begins at the electrically inert tricuspid valve and includes atrial myocardium up to the inferior vena cava. It has got a complex architecture with an anisotropic conduction property. Because of the complex myocardial arrangement and the composition of the cavo-tricuspid isthmus, it could account for slow conduction in the cavo-tricuspid isthmus. And that is a critical isthmus for this typical right atrial flutter. And other atrial flutter, the previous speaker already alluded to. Alteration from tissue damage, from aging, or from surgical intervention could lead to re-entry. So this is again the cavo-tricuspid isthmus. We are seeing it very clearly. This is the IVC and this is the tricuspid valve, and you can see the ablation catheter entering the cavo-tricuspid isthmus, and this is how the catheter locations look in when you are doing a atrial flutter ablation. This is a duodecapolar catheter kept along the tricuspid annulus, that is anteriorly, and decapolar catheter kept in the coronary sinus. So you can see this. And this picture depicts how the wavefront moves in the counterclockwise atrial flutter and clockwise atrial flutter. In counterclockwise atrial flutter, the wavefront goes up the septum and comes down the right atrial lateral wall, and it activates the left atrium from below upwards. So the wavefront is going away from the inferior leads. So the inferior leads record a negative flutter wave. Whereas in clockwise right atrial flutter, the wavefront goes up the lateral wall of the right atrium and comes down the septum, and it activates the left atrium from above downwards. So the wavefront is going towards the inferior lead, so it records a positive deflection. So this is a provocation map showing the typical counterclockwise flutter. We can again see that it is going in the counterclockwise direction. And the Eustachian valve is a valve which got a IVC orifice, and the Eustachian ridge, that is a Eustachian valve continues as a Eustachian ridge. This is a very important structure which transects the cavo-tricuspid isthmus into two portions, one in front of it and one behind it. The sub-Eustachian pouch, otherwise called as a pouch of Keith, is nothing but a physiological depression of the cavo-tricuspid isthmus just in front of the Eustachian ridge. This will be seen in nearly 1 in 11 of the hearts, patients, or in 8% of the patients with atrial flutter. So the pectinate muscle, usually I think you would have read in the Gray's Anatomy that the pectinate muscle usually terminate at the crista terminalis. Sometimes they can extend beyond the crista terminalis onto the cavo-tricuspid isthmus and can pose a challenge in successful cavo-tricuspid isthmus ablation. So the reason being increased thickness of the atrial muscle tissue, then catheter stability due to the non-uniformity of the cavo-tricuspid isthmus, and sometimes due to wedging of the catheter in between the pectinate muscle. So the prominent pectinate muscle laterally is seen in nearly 26% of the patients. So as I told, the pectinate muscle, prominent pectinate muscle laterally is seen in 26% of the patients, and the prominent pouch medially, that is sub-Eustachian pouch, is seen in 8% of the patients. So this is again I'm showing this is the crista terminalis. I think I already told you that we would have read in Gray's Anatomy that usually the pectinate muscle terminate at the crista terminalis. But sometimes the pectinate muscle can extend beyond the crista terminalis onto the cavo-tricuspid isthmus and sometimes into the coronary sinus os. And this is a typical cavo-tricuspid isthmus. This is how it looks usually with the hills and valleys. And this is the Eustachian valve which got the IVC orifice. And this is a very important structure, that is the Eustachian ridge, which dissects the cavo-tricuspid isthmus into two portions, that is the portion in front and the portion behind. And this is the sub-Eustachian pouch. So the prominent Eustachian ridge sometimes acts as a fulcrum and it interferes with the catheter manipulation. So usually when you give a clockwise torque to the ablation catheter, the tip of the catheter should move towards the septum. Whereas in patient with the prominent Eustachian ridge, it will reverse torque, that is the ablation catheter tip will move away from the septum and you give a clockwise torque. So it makes the catheter manipulation along the cavo-tricuspid isthmus difficult. So by using a guide sheath over the Eustachian ridge, we can overcome this problem. So because of the presence of myocardial fibers in the Eustachian ridge, we have to do ablation over the Eustachian ridge also to get a successful ablation. And this is a prominent Eustachian ridge, and as I told you, this will interfere with the catheter manipulation, and by using a sheath over the Eustachian ridge, we can overcome this problem. I told you in 26% of the patients you have a prominent pectinate muscle, and in another 8% you have a prominent pouch, but in some individuals both pectinate muscle and pouch can be prominent. So when there is an intravascular blood flow in proximity to the area where you are giving the radio frequency energy, it leads to heat loss due to by convective heat loss. So the final lesion what you are giving will be suboptimal. So when there is a interference with the heat transfer mechanism due to convective heat loss by flow of blood, so the final lesion which is produced will be smaller, and this is called as the heat sink effect. So the distal RCA and small cardiac vein may run on the epicardial aspect of the cavo-tricuspid isthmus and may cause a heat sink effect. So these are all the conditions I told you which may interfere with our ablation with the cavo-tricuspid isthmus in typical right atrial flutter. One, I told you the prominent pouch. When there is a prominent pouch, the blood flow, myocardial, the blood flow will be less in that area. When you give energy, so the temperature at the tip of the catheter will go up suddenly, so you cannot deliver enough energy to create a good lesion. So in this situation, either we can go more laterally and then do the ablation line, or we can use a irrigated tip catheter. So in the next problem is the prominent pectinate muscle. I said in 26% of patients you can have a prominent pectinate muscle. Again the same problem here. We can go as septally as possible and give the ablation line, or we can use a irrigated tip catheter and do the ablation over the pectinate muscle so that we can give a good lesion. But we should be very careful when you are giving lesion in between the pectinate muscle, because the atrial myocardium is very thin, and if you are little careless it can lead to atrial perforation, right atrial perforation. The other point I said was catheter stability. The cavotricuspid isthmus is not a uniform surface. There is a lot of hills and valleys. So when you have a prominent eustachian ridge, it will interfere with the catheter manipulation. So by using a guide sheath over the eustachian ridge, we can overcome this problem. So these are all the conditions which I said cause difficulty with the atrial flutter ablation. One is a prominent pectinate muscle, then a prominent pouch, subeustachian pouch, and prominent eustachian ridge. And when you use intracardiac ultrasound, we can see this anatomical challenges very clearly, and we can also see the contact between the ablation catheter and the myocardial tissue and overcome this problem, and it can result in successful ablation. So as I told you, when you have a prominent pouch, we can go laterally and do the ablation in the lateral isthmus, or when you have a prominent pouch, when you have a prominent pectinate muscle, we can go as septally as possible and give a lesion along the septal isthmus. But when both are prominent, we can give a lesion along the posterior isthmus. I think most often we used to do the ablation in the posterior isthmus only. That is, starting from the 6 o'clock position in the LAO view, we can go up to the IVC and connect this line, make the line complete. So these are all the anatomical challenges I already alluded to. So when you have a prominent subeustachian pouch, you do the ablation line laterally, or you can use a irrigated tip catheter. So when you have a prominent pectinate muscle, you do the ablation more medially, that is more septally, or we can use again ablation catheter, get rid of this problem. Or when you have a patient with a prominent eustachian ridge, using a guide sheath, we can overcome this problem. So dear friends, to conclude, whenever you are contemplating for a radio frequency ablation of cavotricuspid isthmus for the treatment of typical right atrial flutter, you should be familiar with the right atrial anatomy, both normal and abnormal. So when you do imaging with intracardiac echocardiography, we can overcome these challenges, and it helps us in doing a successful cavotricuspid isthmus ablation. I thank you very much. I stop here, and I'll take up any questions. I'll be happy to answer.